focus for today, we're going to look at why the opioid issue is a concern to the elderly and a concern to the community at large. Everyone knows that there's an opioid issue in the country, in the state, and in the county, right? Okay. Identify the resources available in the community, and Jessica's one of those resources. And then describe the benefits of the COAT program, which is a promising practice in Wicomico County. So if you look at some of the summary statistics, opioid overdose, 4th leading cause of death in Maryland. I'll repeat, it's the 4th leading cause of death in Maryland, only after cancer, stroke, and heart attacks. That's scary. And it's very concerning. And this was data back in 2016. We know those overdose deaths have skyrocketed again this past year, but there has not been a full release of overdose death data for 2017. That's this close to being released. So 1,468 deaths. It's equivalent to 150 per month and 5 per day. This is for the state of Maryland. Scary. So part of the reason why we're seeing an increase in 2016 and 2017 is the introduction of fentanyl. The fentanyl overdose-related deaths have skyrocketed. They've increased 248%. And you, as many of you know, a lot of your clients are prescribed fentanyl through pops or patches, but there's also a very large illegal market coming out of China. China has actually decided that the United States really has a market, and so they are sending it to the United States for use, and it's very easy to produce. Heroin-related overdose deaths have almost doubled. It's 71% increase. But when you combine the heroin with the fentanyl, it's a real big concern. And it's we also have issues with the prescription opioids, but that is declining, and you'll see some of that in some of the data. And the other concern that, and I think Jessica can acknowledge this as well, is that fentanyl's being introduced into cocaine. And a lot of these individuals that are buying the cocaine don't necessarily know that it's being cut with fentanyl, which is causing a surge in the cocaine-related overdose deaths, correct? So what's happening in our community is we're seeing a rise in criminal activity because, believe it or not, there's lots of things that people can steal from you that they can then use to buy some of the heroin or fentanyl. Deaths are on the increase, and then the cost of health care has skyrocketed because of the heroin and opiate issues. So the thing that I like to state, and we do this when we do our opiate forums, is this is not an addiction issue. It's a community issue. It affects each and every one of us in some way, shape, or form, whether or not it's a personal issue with our own use. It's a family issue because many of us have had family or friends that have been addicted to heroin or other opiates. Or you have been a victim of crime related to the whole drug use issue. And think back, some of you are maybe close to my age. When I thought, when I was growing up, of a heroin addict, think about that for those of you that are close to my age. What did you think of when you were thinking of a heroin addict? What'd they look like?
Some long hair hippie from the 70s.
Yes.
Janice Joplin.
And what's the face of the heroin addict look like today? Got that right. It could be your neighbor, could be any one of us in here at any given time. So, why is this occurring? So we have a deliberate misuse of prescription opiates or illicit drug use. The one that I have up here is typically related to prescribers, because sometimes when you go to a physician, they're human. They may prescribe you the wrong dosage of medication, or they may prescribe you the wrong medication in general. And then you take that prescription to a pharmacy and you may get the wrong prescription. And hopefully this does not happen often, but it does happen because we are all human. Misunderstanding of directions for use. Okay, many of us deal with the older adults. How many times have you gone into a home and there's been 10,000 prescription bottles and you're asking, which ones are you taking? And they say all of them. Happens frequently, doesn't it? There is not a medication reconciliation process for some of these people. They don't know how to take these medications, and that's a concern. We need to make sure when people are getting their medications from a physician or from release from a hospital that there is a medication reconciliation process so that these individuals know what they're supposed to do and what they're not supposed to do. And then the whole issue of combination of prescribed or illicit drugs with alcohol or other medications. I just mentioned that they're combining cocaine, heroin with the fentanyl, which is a huge issue. It's also a big issue when you have prescription drugs like for anxiety, benzodiazepines, the Xanax, the Ativans, and alcohol along with the other heroin and other opiates. That's a recipe for disaster and a recipe for death for these individuals, particularly if they don't understand how to take their prescribed medicines. So who's at risk? Anybody. But there are issues specific to certain individuals, such as those that have chronic pain issues. How many of you have been to a doctor and they prescribed pain management medications? Yep. I have back problems. Doctor always wants to prescribe something for back pain. Nah, not doing it. But we have individuals that have that chronic pain and they're just not able to function without some type of management. And those individuals are extreme risk for overdose. Individuals that have been discharged from emergency medical care following an overdose. Why is that important? Why is that an issue? They have many times naloxone on board, which takes them out of the overdose, and they think that they have to take more because of the naloxone on board. Individuals that have been detoxed or abstinent for a long period of time, again, that goes back to the fact that they think that they can go back to using the exact same amount on the street, whether it is a prescription opiate or if it is an illicit drug, and they can't because their tolerance is changed. I've already talked about the combining of other medications, huge issue. And then those that have been recently released from incarceration, they've had that long period of abstinence, hopefully. I will not say that there's not drugs in jail. We know that there are in some jails, but we hope that they have abstained. Why are we seeing this? I'm going to give you a history lesson in Wicomico County. This may pertain to other jurisdictions. In 2012, and Jessica can help me with that date, we had a physician that was very happily writing prescriptions to anyone and everyone that wanted them. I think the total number of patients that they had was 4,600. I get a phone call at 11 o'clock one night. I was sick as a dog. I think it was in January or February. And it was from my boss at the state. And they said, heads up, we're closing a provider in your community tomorrow morning at 8 a.m. I said, well, what provider and why? So they tell me, and I said, what? We have 4,500 people that are impacted. And they said, nope, notes going on the door, no patient access. These are pain management patients. I say that with quotes. If you walked into the office at any given time, and I've been in that office because my husband got referred there, you would see people asleep in the chair. They would have drool coming out of their mouth, and there would be upwards of 30 to 40 people in the office. So having been in this office, I knew what was happening, and I thought, uh-oh, we got a problem in Wicomico County. So that started our trend downward because we had all of these patients of this provider no longer able to seek care for their pain or their addiction, whichever it was. Sometimes it was both. I see this happening. Am I going to want the DEA and the Division of Drug Control sitting on my doorstep saying, excuse me, but I need access to your records? I would not do that. So I understand why they didn't do that. And that was the first large provider in the state of Maryland that was shut down like that. There's been many, many more since. But we kind of sparked this, and the state Department of Health started what they called a fusion team that consisted of law enforcement, FBI, boards, licensing boards, sitting down and looking at what's going on, and is there a reporting process, because we knew that there was a problem with this provider and had done our due diligence at the health department of making sure that people knew that this was a provider issue. But things don't generally happen real fast in government. I work in it, it doesn't happen. So the other issue, we have more pure heroin on the street. We had some physicians that were prescribing legal opiates to their patients, and then they were no longer able to get them. So how do you decide how much heroin to use that's equivalent to whatever milligram you were getting of an opiate? There is no conversion. So that's how overdose occurs. We've talked about the inclusion of the fentanyl with the heroin, and again, it's also occurring with cocaine. So they have become very, very good at manufacturing, and this is a true business trade. And then again, the periods of abstinence going back to using the same amount of heroin. So impacts to the community. This is huge, and you'll see some data on return on investment that looks at some of this. But you have the first thing that usually goes is the loss of your family support. So you have no one that's sitting out there trying to help you and coach you and move you out of this world of addiction. You only have those that are trying to keep you in it, either your dealer or your buddies that are using as well.
Or your enabler.
Yes.
And a lot of enablers.
It's jacking up the cost of treatment. Just think about how much more treatment is out there now than it ever was before. But is it enough? No. The increase in crime. I think the latest I heard the sheriff say that 90% of the crime that's occurring is related in some way to drugs. So then just an increase in the cost in the criminal justice system, increase in cost in healthcare. The last bullet you see, it's $700 billion a year in increased healthcare cost, crime and lost productivity. I mean, that is huge. And the thing that people don't generally think about is a lot of these people used to be in employment. Well, when they get so heavy into their addiction, they can no longer stay employed because they have to go after that next fix, which is very frequent during the day. So we also have a decrease in our tax base. So there's less money out there to help our community treat these individuals. So in Maryland, the total number of overdoses has risen steadily since 2010. We began to see our spike again in 2012 and started working on this issue then. And then when the governor came into office, he put together a task force to go around the state to look at what is it that Marylanders feel we should do to address this issue. The sheriff and I both were there testifying as to what we thought we needed, as well as other individuals across the lower shore. So, for all of you data geeks, do I have any? This just shows you the impact, unintentional intoxication deaths occurring in Maryland. And you see this, the rise actually started in 2011, but if you look at its extreme impact, it started in 2016. And this data is only through September of 2017. So as you can see, this is what has occurred in Maryland. This is opioid-related deaths, and I'm going to get to some lower shore data in just a minute. So it's still rising. Heroin. See a little dip there? It's because fentanyl's taken its place. See that? 2016, 751 fentanyl-related deaths. 2017, again, it's not a full year, 1,173. So, again, I think the last count, there were over 300 clandestine labs in China manufacturing this and shipping it in. It takes a whole lot less fentanyl to get the same high as it does for heroin. So then we talk about carfentanil. Does anybody know what that is? It's an elephant tranquilizer. They are beginning to cut the heroin with carfentanil because it's cheaper. Fortunately, at least at the last time I checked, we had not had any carfentanil overdoses in Wicomico County. Yes, thank you. But there have been some in Maryland. And I wanted to pull this up because a lot of people think that the opiate issue is related to prescription drugs in the beginning. Yes, it was. As you see, it's declining. And then the cocaine-related deaths. Again, we've seen a spike beginning in 2016, and then a significant spike in 2017. And don't forget, alcohol has not gone away. Alcohol is still a problem. And yes, people are still dying from alcohol-related issues. So our local data, and I'm going to leave this here for just a minute because, again, alcohol is still an issue in our lower shore. It's still one of the greatest reasons for admission for treatment services. And I don't want us to move away from thinking that this is not an issue. But if you look at the difference between 2016 and 2017. This is the overall overdose deaths related to any cause. 2016 in Wicomico County, we were at about 49. And 2017, again, this is preliminary data, we have dropped to below 30. There's reasons for that, and I'll get into that in just a minute. There's been not as much of a decrease in some of the other jurisdictions, but their numbers were smaller to begin with. Prescription opioid-related intoxication, if you look at the green bar for 2017, that's a huge difference, would you not say? And this is the heroin-related intoxication deaths, again on decline for Wicomico County. Opioid-related intoxication deaths, again, that's all opioids, again a decline. And I showed you the data earlier about the state of Maryland. They had a huge spike in fentanyl-related intoxication deaths for 2017, right? See what's happening in Wicomico County? Do we take that as a success? That's a small success. And Jennifer and I both will say, we haven't fixed this until we don't have any overdose deaths in our county. So we're making progress. And our biggest spike was January, February, March of 2016. I was getting the call at 10, 11, 2 o'clock, 3 o'clock in the morning from the then state's attorney, Matt Massarello, saying, what in the world's going on, Lori? We got to do something. And I'd tell him, I need some sleep. Can we talk in the morning? Because he was not dealing well with the fact that we were having all of these overdoses. So we did some work. So I just wanted to put this up here. Prescription opioid misuse is a major factor for heroin use. People need more opiates, so they can't get them the legal way, so they go and get them the illicit way. And 7 out of 10 people who used heroin in the past year also misused opioids in the past year. So looking at what in the world were we going to do? You know, as I said, we started addressing this problem in 2012. We didn't do a whole lot because we didn't have a whole lot of resources. But we, during the campaign cycle, when the lieutenant governor and the governor came down, we were hitting them very hard with, we've got to do something. This is not just a Wicomico issue. It's not just a Lower Shore issue or a state of Maryland issue, but you are organizing the state of Maryland or planning to. So we need to know what in the world we're going to do. So the task force that he started, they came up with multiple recommendations, and they have implemented many of these. The whole access to treatment and recovery services. You know, we felt like we were flush with treatment services until 2012 came, and then we realized, oh my, we don't have what we thought we had. The recovery services were always lacking because prevention and treatment was always targeted. But what do you do when somebody finishes treatment? They need that support moving on throughout their life, which is the recovery piece, and that was lacking. We also knew and targeted the whole quality of care issue. You know, there's quality issues in every type of organization, but we knew that there were what we call in the treatment world a gas and go treatment provider. And what that means, at least in my mind, is they go in, they get their medication, which would be methadone or whatever medication it was, and they don't get any treatment other than that. And then they're out the door. And so he heard that was occurring in Maryland, and he says, we've got to put a stop to this. And I said, thank you, sir. You know, healthcare has their privacy issues. And the sheriff and I have talked so many times that it would be so nice if he has someone that is in need of treatment and he brings them to my doorstep and says, can you help? That I can go back and say, this is what we did, Sheriff. But you know what? Unless the person says, yes, we can't do that. And there's a significant lapse in what we call the whole treatment realm because there needs to be some back and forth in addressing this issue. The improvement of coordination and the sharing of public health information. 2012, I didn't have access to the names of the people that were being treated by the physician. The only way I knew that they were being treated is they called and said, can you help me? So we've made some improvements there. Helping parents, educators, and others to prevent youth use. You know, I told the lieutenant governor when he came down with his panel, we've got to start before it starts. And that's going to be targeting the youth. And so with the Start Talking Act last year, they required education in the 3rd through the 12th grade to focus on opiate misuse. And I applaud the education system for that. Alternatives to incarceration for nonviolent offenders. This actually has some good and bad components. They started what they call, the legislation was called the Justice Reinvestment Act. And what that does is that actually allows for, maybe not allow, forces treatment for the nonviolent offenders as opposed to putting them in jail. I'm a firm believer, probably to a detriment, that some people need to be incarcerated regardless of what their crime is, because that's the only way they're going to get help. So this has some issues. One of the biggest issues that I face when I go up to the Justice Reinvestment Oversight Board meetings is the fact that it decreases the leverage that the justice system has over these people. And I'll give you the example. An individual previously that had been in drug court, let's say, they asked to be in drug court rather than be incarcerated. They go out and they use and they violate the orders that are in drug court. There's now a 15-day maximum penalty. So their sanction is it's less than 15 days. Many times these offenders can ask to have their sentence revised. I don't know what they call that. Do you? And these individuals that typically had a 5-year sentence and there was that hammer hanging over their head can have it reduced to less than a year. So there's no incentive for them to stay clean and sober in the community because they're not going to be sanctioned for more than 15 days. And 2, they've already served their time because they had a 5-year that's been reverted back to a year. So some of the legal issues surrounding drug treatment has gone for the better, but some of it has pushed us a little bit further back. And then the whole issue of public awareness. I've done some presentations where people will say, this doesn't impact me. This doesn't impact my family. Doesn't impact my children. And I say, you have your head in the sand because this impacts every one of us in the community. So I know that there are people here from other jurisdictions. I can only speak to what's occurring in Wicomico County. Some of these are overlapping in other jurisdictions, but I wanted to bring up what's occurring. So the prescription drug monitoring program, what that is every prescriber has to, as of July 1, be registered with CRISP to enter information on the prescriptions that they are making that are Schedule 2 through 5. July 1, they have to go in and look to see who else may be prescribing for these same individuals. In Maryland, it was never a requirement for use. And I sat there, I said, then why do we have it? Because there are physicians that don't want the added work to go in and look at this. And so what they did was they allowed to have delegates to go in for them. So if I'm a physician in XYZ practice and Jessica works for me, Jessica can go in and look for me. We have medication-assisted treatment. We have, I think, I know we have one of the longest running medication-assisted treatment programs on the shore. We were the only one up until several years ago, several meaning more than one. When I began with the health department, and I'm not going to say how many years ago that was, in the substance use world, we had 35 medication-assisted treatment patients. 35. At our peak, we had over 300, and that was just recently, before these other two providers came on board. Now, you have to understand that these individuals have to come into a dosing unit every day, 6 days a week. So there's a commitment level there for those individuals. So they're really wanting to either A, get their methadone, or B, to get clean. You never really know unless you know the person. 2 new programs opened up in Wicomico County, one right across the street from our dispensing unit. They said, oh, we didn't know you were there. So that has created what I call healthy competition. We've had people leave our medication-assisted treatment program, go to a new one, and then come back. Many of the people that we have served, and one of our former medication-assisted treatment nurses is here, and I see her shaking her head. They will come back because we do things the right way. And I had a conversation with a member of the drug task force last night, and the comment was, can you just be the only provider in Wicomico County because we know that what you're doing is going to be the right thing? And I said, yeah, not so much. That it's consumer choice. We also have the only mobile unit that provides methadone in the state of Maryland. There will not be another one unless the DEA allows that to happen again. They shut it down. And we provide mobile methadone services out of Worcester County. Everybody's heard about prescription drop-off sites. If you have used medications, or your families that you're visiting or working with have used medications, get them out of the house. Get them into a drop-off site. We have 8 sites. I think it's 8 sites in Wicomico now. How many of you carry naloxone? 1, 2, 3, 4, 5. We gotta get many more of you carrying naloxone. It brings you out of an overdose. It cannot hurt you. And it's not addictive. We all have people go everywhere in the community. People will overdose everywhere. The most frequent place that I hear on my radio is the Walmart bathroom. And in close numbers, it's Royal Farms bathrooms.
Why do you think people choose a public bathroom to use? Do you have an idea?
Are they crying for help?
Yes, because they know somebody will find them. Right.
We provide education and the naloxone dispensing every second Tuesday of every month at the public library. If you would like to get trained and get the naloxone to carry on your person, because you never know where there will be an overdose, get trained so that we can make sure that you're able to help someone that you come on the scene to. Prevention and outreach, age-old opportunity, never goes away, but when you have significant budget cuts, the first thing that goes away is the whole prevention piece. When I came on board in 2008, I made a pledge that I was not cutting prevention, and I did not cut prevention because I felt that that was the key to the success of the public health of Wicomico County. Peer support. I'm not going to go into a whole lot of detail on peer support, but we have a program, and I'll get into our program, but we hire peers, people that are in recovery that have been down the same path that some of these other individuals have been, because they can walk the walk and talk the talk and get these individuals engaged into treatment. We hire individuals that have a minimum of 2 years of clean time, and they do a lot of work centered around outreach and linkages to treatment. When we had our physician go awry in Wicomico County, we started working with the hospital and developing educational programs for prescribers so that we could make sure that they understood what the golden standard was for opioids and opioid prescribing, because there was considerable fear among the prescribers in the county that they were going to be targeted as well, and so we wanted to make sure that they knew what was occurring. The next thing is overdose fatality review teams. This is not a fun time. Once a month, we review every overdose that has occurred in Wicomico County. And by we, I'm talking about a community group that includes public agencies, law enforcement, social services, physicians if they wish to attend, and we look for missed opportunities. Where did we miss the opportunity to engage these people into treatment? And one of the biggest issues that we've seen is those individuals that apply for disability, they have no requirement for drug testing. So the first thing they do when they get their back check is they go buy and buy a lot, and they overdose. And that's one of the recommendations that we've put up to the state, that there needs to be some level of accountability for those individuals moving forward. We also have case management for the addicted individual. I don't think I have to explain that. And I'm going to let Jessica talk about the encouraging public to call 911, because there's a new law that went into effect.
It's the Good Samaritan Act law, which basically says that if you're present during an overdose and you call 911, when the police get there, that you will not be arrested for that. You know, we know that we can't arrest our way out of this problem anymore, so that it protects people from being prosecuted for just trying to help people.
And then we have our COPE project, which I'll go into more detail in just a minute. And more recently, every jurisdiction in the state of Maryland was requested and did develop an opioid intervention team. Wicomico County, the county executive requested that one be developed, and what we do in those groups is we look at the trend data, we look at what the needs are, what the gaps are, and we involve many public agencies as well as treatment agencies in that discussion. And one of the, I guess, things that has occurred out of this that's kind of new and has not been put out in the press yet, but when we were going around doing our opioid forums across the county, the theme that the county executive heard, and it wasn't just me banging on his door saying we need more treatment slots, inpatient. So he heard it from everyone. And we are engaging the Department of Public Safety and Correctional Services in this task, and that we are asking to utilize the Poplar Hill pre-release unit that was vacated a little over a year ago, maybe 2 years ago, to turn that into a three-pronged approach treatment center that will consist of 23-hour observation and detox, a residential treatment center, as well as a recovery center, recovery resource housing. And we're at the very, very beginning of the planning stages on this, but the opioid intervention teams work because this was an identified need, and we're moving forward with it. It's going to be a regional program, not Wicomico specific. So we're excited that that's happening. So the COAT team, I think I've spoken on this 100,000 times, and Jessica is she is a COAT member. When we looked at the governor's report, when he went around and met with every region, the thing that was missing was treatment on demand. If you need treatment right this minute, you don't get it, because you'll go to the hospital, they'll release you, they'll say we'll get a bed for you, and that might take 7 to 10 days if you're lucky. So we decided in Wicomico County that we needed to do something a little different, and that state funding, we couldn't wait for it. Government funding is slow and it's scarce, so we knew we had to do something.
And I'll tell you, time is lives, in my opinion, from working with a lot of heroin addicts and talking to people who are in recovery. When they're ready to go to treatment, they're ready to go. If you talk to them tomorrow, they might not be ready to go anymore. So you have to act on when that window of opportunity is there. And we were missing those windows of opportunity.
And we also were looking at what's called essence data. The state has a database, it's, see if I can get this right, electronic surveillance system and early notification for community-based epidemics. I think I got it right. So what this does is it pulls data from hospital ER, it pulls data from pharmacies, it pulls data from multiple places to look at spikes in different things. So now opiates is on there, so we're able to look at those gaps as well. But we wanted to fix those gaps and to address those gaps in Wicomico County. We knew that we had a target population, and that was people that were overdosing. And I say this every time I speak, and I'm not alone in this, but we're seeing a decline in Wicomico County, but one overdose death on my watch is one too many. I don't care who you are, I don't want one. And Jessica feels the same way. So we wanted to look at case finding. We already knew who those people were, but we wanted to make sure that we knew them well. So our goal was to intervene before the addict becomes a statistic. How many times do you think somebody overdoses, 911 is called, they're transported to the emergency department before they die the next time? How many times? I see 3. Any other guess? 1? A lot of times it's 1. But you know, they can go in there upwards 5, 6, 7 times. We've had a young lady in Wicomico County, and when I say young, 26 years old, she overdosed 4 times in 1 week. I hear a groan. Think about the resources there, but think about the fact that that was 4 times she was brought back to do it again. And that's one of the things that we hear out in the community. But my statement is, each time, if we touch her life, it may be the time that she says, I've had enough. I don't care how many times we have to touch a life, we're going to do it so that we can get them where they need to be. I already talked about how we started this process with the state's attorney's office. We were responding to a significant number of what they call bad batches of heroin, and that's because the fentanyl supply had come into Wicomico County. So what does COAT stand for? Community Outreach for Addictions Treatment. We're wrapping services around those individuals. We went to the county and the city and said, okay, this is what we want to do. We want some money for a year to show you that we can make a difference in these people's lives. We want some money for a year so that we can show we can make a difference in the recidivism rate. We want some money for a year so that we can show you that there is a return on investment for every dollar that you put into this program. And I was pleased to hear, yes, we will do it for a year. I will tell you that this program is currently still funded because we showed a difference. Our goal at the time was to identify those that were in need of education and outreach and be that bridge to treatment. As we've said, you identify an individual that has overdosed and they want treatment, but if you don't help them right that minute, they're going to go back out and use because the pain and suffering from an opioid addiction is huge. People will describe it to you that it's the worst pain they've ever had in their life. It's like the flu magnified 100 times.
And I was told by some that after the first high, it's always, they purchase and buy after that to stop, to avoid being sick after that. It's like an instant addiction, and you know, after the first high, it's about not being sick after that. It's about just maintaining.
So our desire was to meet people wherever they were. So if they overdosed in the community and we were able to get to their house, that's where we met them. If they were at the hospital, that's where we met them. But then we also met them where they were in relationship to treatment. Not everybody has the ability to say, I'm going to go into a 28-day treatment. Well, what about if you have a job? What about if you have a family? What about if you have children? What do you do then? So we were willing to work with people so that we could identify where they were in relationship to treatment. Again, we wanted to be that bridge to treatment, and I keep saying bridge because that's basically what we are. So what we saw in 2015, 100 overdoses went into the emergency room in that calendar year, January through December. 188 overdoses had occurred in the first 6 months of calendar year 2016. And this was the data that actually allowed us to gain the funding from the county and the city, because they said this is ridiculous. This is absolutely taking away scarce resources of law enforcement, EMS, and the hospital emergency department. So data can be your friend. So a collaborative effort with the county government, Wicomico County government, City of Salisbury puts in a small amount of funding. Of course, the state's attorney, I felt like was my biggest cheerleader at the time, saying, yes, we need to do this. Sheriff's Department, we have a contract with them because they send their CIT trained officers to go, for the most part, to go out with our peers that we've hired to overdose events and to help link people up with treatment. And I'll let Jessica talk about her involvement. City of Salisbury Police Department, the Salisbury Substance Abuse Community Center, which is now the Resource Recovery Center, and then PRMC. Before the COAT team actually got functional, PRMC would not send me one piece of data related to one overdose in anything, any relationship. They said it was a violation. Once we initiated our COAT team, I get monthly patient identifiable data from the hospital on overdose deaths and overdose cases. And I say the overdose cases because those are the people that we want to go out to with law enforcement so that we can try to get them into treatment. we have been really successful getting individuals involved in treatment. Do you want to talk about the sheriff's department role?
Absolutely. So we are paired up with peers, and when, where he says CIT trained officers, for those of you who don't know, that's crisis intervention team trained officers. They are handpicked often for their communication skills, for their understanding of addictions and mental health issues, and they go through a 40-hour certification course through the police academy, where they are given special tools to de-escalate people in crisis or respond to people in crisis, okay? And I would say that someone who's overdosing or somebody who has, or who is deep in their addiction is someone who is in crisis, okay? So these are the people that we select to go out into the field, paired up with a peer, and we go looking for these people, okay? We have information from overdose lists of overdoses we've encountered, or people that we have arrested for possession, et cetera. And we go out there and we check on them, and we look for them because we want to help them, okay? So I kind of see it as being a good ambassador. This is one of those few times that law enforcement can get active in something that is proactive and not reactive. And if we can go out there and help somebody, you know, and I told Lori this before, 99 out of 100 police officers will come to their police interview, and when I ask them, you know, why do you want to be a police officer? They say, because I want to help somebody. And I say to them, well, helping means a lot of different things, doesn't it? Helping might mean giving them another dose of Narcan, or helping might mean, you know, going out, paired up with someone who's specially trained in how to reach people who have addiction issues, and offering them some help. So I am there we are there as protection. We are there because we do go into some neighborhoods that aren't as great, you know, low socioeconomic places where there is a lot of crime, unfortunately. And, you know, the first thing I say when I get to the door, because I usually go up to the door first, you know, it's just a safety issue, is so-and-so in here? By the way, they're not in any trouble. Okay, because you know, a lot of these people have very negative interactions with law enforcement, and I don't want them to be scared to reach out and get some help. So, and that's kind of the partnership that we've put together. And I find that with the information that we have and the information that they have, we can reach out to people, you know, and I think that's where the missing link is. That's the gap there, is that, you know, you can get into therapy and you can be forced to do things all day long, but you know, who's going out there and looking for these people? Maybe they just need somebody to bring them up from where they are. And that's why it really kind of spoke to me, and I was really happy to be involved in the program, and I emphatically support it, and I think it's a great thing that we've done here in Wicomico County.
So we hired peers. Again, these are individuals that have a 2-year clean time. And keep in mind that people that are in recovery do relapse, and we sometimes expect that, so we have to put resources in and around those individuals. We make visits with law enforcement to hotspot areas. As I said, we were began receiving overdose ED data, so every time somebody entered the emergency department, I got notification. I also started getting what they call CAD notifications. So anytime emergency medical services, EMS, is dispatched, I get a text message that says potential overdose has occurred at this residence. So we were getting that, and we were also getting crime data once a month. So we were getting identifiable data on these individuals so that we could hopefully target as many of them as possible. We pay for about 10 hours a week of law enforcement time. We use, again, primarily officers that have been CIT trained, and they have to have 2 years of documented recovery, not the officers, but our peers. So we go out everywhere and talk about this program. We went to every local law enforcement roll call. It's a lot. We hit city and county councils, homeless shelters, anywhere we thought that individuals may show up or they may know about individuals. So what has happened? I am so pleased with this data. We targeted 231 individuals last year. Those were the number of overdose calls that we responded to. 116 engaged in treatment. The national average is 22%. We've hit many more. We had several hundred outreach efforts, so going out into the community. Of those 231 individuals, we contacted them almost 1,400 times. So you can't make one contact and expect success. And that's the success of our program. We have seen for calendar year 2017 a 32% decline in emergency department overdoses in Wicomico County. I say that with a breath because any day it could jump back up. But I will say that of the cases that come in now, more than half of them, excuse me, are from out of county or out of state. Last month, I showed you the statistics. In 2016, we were having 44 a month. Last month, we had 7, and 6 of those were from out of county or out of state. I think that's progress, would you not say? We also have been designated a promising practice from the National Association of City and County Health Officials. This is additional outcome measures looking at first 9 months of 2017. The bottom line is the state. I want you to see that everywhere on Wicomico County it says decrease. Everywhere on the state it says increase. I keep getting asked from the state opioid operation command center, what are you doing and how can we replicate it? So we have been taking this around the state. We also engaged Beacon through SU to do a formal program evaluation. They determined that our return on investment was for every dollar spent, we saved $6.66. It's a lot of money that's being saved. We had a 62.68 higher rate than the nation in assisting addicts into rehab, and they've made some recommendations such as longitudinal follow-up. So we have been able to leverage other funds. We have, 3 minutes. We have been given dollars to do work with the Safe Streets program, which works with law enforcement. We were given dollars from Department of Human Services, the old DSS days, to respond to substance-exposed newborns. And there were approximately 7 to 10 substance-exposed newborns in the nursery at any given time. We had none last month. The city has continued our funding. They give us a small pot of money, and the county actually expanded our funding, which in this day and time of governmental funding for a county or a state to give you additional funding, that speaks volumes. So there's my contact information, and Jessica can answer all the questions.
I thank you, and I know everyone is like, okay, she's standing between me and lunch or the bathroom or getting out of here. I'm going to talk with you a little bit today, and you've seen some of the booklets that I bought out front from the Department of Aging, as well as some that was put there by a legal services provider on managing someone else's money. I'm going to speak with you in terms, and I see on the program it has scams and financial exploitation. So I just want to talk with you a little bit about financial exploitation and some of the ways in which it happens, but my focus is going to be on fiduciaries. And I'm going to ask you a question. And has anyone in here completed their advanced care directive? Yes. Okay. So are there any attorneys in the room? One, yes, okay. So you might be able to help me out with some of the language here. And for those of you who have not done this, I'm going to get this out of the way first because this is sort of like my testimony. If you don't have an advanced care directive in place, or if you've not talked with your loved ones about your financial decisions and your medical decisions, I encourage you to do that. And this is not something for the elderly or the older. It is for everybody 18 and over. And Maryland now, through the Maryland Attorney General's office, has a website and a location that you can go to and put this in place. And sometimes as professionals, as the gentleman said earlier today, I believe it was Art, Mr. Wynn stated, self-care is important. But as we're advocating and providing services to others in the community, we want to make sure that our stuff is together as well. And my testimony is this was all academic to me until I was flying from a conference from Las Vegas, and I passed out on a plane and got home and was told that I had 6 to 9 months to live because I'd been diagnosed with an illness. So I'm talking all the time with AARP for Legal Counsel for the Elderly about advanced care and healthcare decisions, and here I was with not one in place for myself. So I actually used the Maryland's website and put one together. So I'm encouraging you to do that as well. I'm an individual, I'm from the South, so all of my family's in the South. There's no one else here. So if something happens to me and I were to drop dead now, I'm happy to say there's somebody that, you know, Donna or Cheryl would be able to call on my interest. But that wasn't always the case. So I'm encouraging you, along with the self-care, is to get your business in order, and we can do it. And once you go through that, you're able to help your clients advocate for themselves and put stuff in place for themselves. And we have several kinds of avenues for that. There's the Advanced Care Directive, there's a DNR, there's someone who's a representative payee, but they're all called fiduciaries. And the fiduciary is basically an individual who's been assigned to manage someone's money or property, and it doesn't matter where you are, whether you're a family member or not. The law requires the money and the property to be managed in the best interest of the person. And sometimes fiduciaries happen to be family members, so a lot of the calls that I get at the Department on Aging and before are issues with family members, and mom and dad have not really thought through who they've made their power of attorney or the fiduciary for them. And so the majority of the time has been spent trying to settle the battle between siblings that mom and dad didn't do when they were growing up. So now I'm listening to 40, 50-year-old people battle it out about managing someone else's money. So the fiduciary must be someone that's trustworthy, honest, and act in good faith. And this has legal responsibilities with it as well. The legal responsibilities require you to act in the best interest of the person represented. To keep their money separate from yours is a big issue, and to keep good records. As we're moving forward, because in honor of the weed celebration today, the Social Security Administration has a blog out, and they're now they're going to put more avenues in place for dealing with rep payees through the social services, social services division. So that's something to keep an eye out for. Types of fiduciaries, as I stated earlier, one are agents under a power of attorney, guardians, or conservators. I work a lot with Donna because she's over the public guardianship program. And in the state of Maryland, we have about 895 persons who are in the public guardianship program who are 60 and over. It is the encouragement and the work of the Guardianship and Vulnerable Adults Work Group through the Judicial Council to make sure that the public is aware of the process for applying for guardianship, so that you will become guardians, or someone will be guardian of you who knows your lifestyle, the kind of quality of life that you live, and the decisions that you would make on behalf of yourself if you weren't able to do that. And if you would go to marylandcourts.usa, I believe it is, and I can give you that information later, but there are training modules for the guardianship process. And now it is a law, as in January, anyone who's applying to be a guardian will have to complete those training modules and the modules, and then they'll receive a certification before they're allowed to be a guardian. Some other options for guardianship is alternative dispute resolution and mediation, because sometimes, like I said, the majority of the calls are family members who are at each other's throat about the care of that loved one, and so that's going to be the next step with that piece. Sometimes there are other fiduciaries involved. For myself, I have one person who will make the medical decisions for me. and then someone else who will make the financial decisions for me. I try to make that decision based on how well they can get together, how well they know me and my lifestyle, that if I'm able to make those decisions, they can do that. So sometimes you'll have co-agents as well. Then you'll have successor agents, and then there are other types, like there's a guardian of the property, a guardian of the person. I think for the most part with Donna, with our program, Donna is like the guardianship of the person, but there might be an attorney or someone else assigned as guardian of the property. Then we have the trustee under the trust, and then the representative payee. Anyone receiving government benefits, they require special fiduciaries. It is important to work with them and keep them informed when you are representing someone else's money and there are other folks involved. Family members and friends are the most difficult, as I keep saying, to work with, but just follow the duties and obligations that's outlined for you. Sharing information may be, using your best judgment. Sometimes when you're a guardian for someone and you'll meet that family member, that you're not obligated to share the information with them, but if it's going to make the process easier for you and oversight for that person, go ahead. Then there's some family members that you just don't want to tell them anything. You have to use your best judgment and document. Then you realize in the end that you're responsible for the decision because there's a legal obligation involved. And if you can't get everyone on the same page, then we encourage that you seek out others, counseling or mediators for disagreements. Watch out for financial exploitation. Most times the financial exploitation, it does come from outsiders. But for the most part, it's family members. The last presentation, Ms. Brewster talked about the opioid. What we're experiencing now is that there are family members who are using opioid and they're exploiting their older person in their care. And the older person is reluctant to report that for fear of being placed in a long-term care facility or damaging that relationship that they have with that person that's exploiting them. So as she mentioned earlier, it ties in, and the opioid issue affects all of us. The person may still control some of their funds in some cases, and they will continue to be exploited because the person might be controlling some of their funds, but then there'll be others who will exploit them by constantly borrowing money, indicating a need for it, or just outright theft in some cases. Some may not have control and still be exploited, and those are basically through outsiders. One issue that we have in the state of Maryland is the funeral home fraud. Have you heard of that? Well, people are trying to put things in place for life or death, and they're doing pre-packaged or pre-arranged funeral arrangements, and you're thinking you're paying for one thing, but then it's not what you paid for, or you're finding out it's just a mess, and they're taking advantage of you. In the District of Columbia, if you've been following the media, there was a case where a couple of funeral homes were asking for the life insurance policy before they would even do the embalming or burial. So in the last 6 months, I think they've closed down 3 funeral homes that experienced that. So you have to be careful. Other outsiders is the dating scam. Most of the thing for older persons is isolation. Isolation is not good for anyone, but it definitely has impact for older persons, and that they are easily exploited. The dating scam is one where I know of one case where the lady's husband had passed, and he really left her financially stable for a good life ahead. She was lonely. She decided to go online, and she met someone online in another state. They conversed almost daily, she said, for about 3 to 6 months. They'd not met each other. She indicated something was going on with one of the retirement plans or the funds that she had. The gentleman offered to help her because that's what he'd done for himself. And he ripped her off to the tune of about $1.2 million. So, and she was afraid to tell her children or her friends, and she was so embarrassed by this. So a lot of times we have people who are exploited financially by others, and they are embarrassed and they're not telling. And you'll notice that they're more depressed, they're a little bit quieter, you'll notice the shift in their personality, and normally that has taken place. Also, we have it where they're, I call this one for white males, middle-class males are being exploited. They're being offered opportunities to make investments. And of course, we want to all increase our retirement benefits, and they're finding out that money is being stolen from them through investment scams they're calling in. And they're not reporting it because for various reasons, but mainly because of the embarrassment with this. There are other scams as well. We have the IRS scam. I'm sure you guys are familiar with that one. Okay. Well, the state of Maryland in January, there was a group called Protect Identity Theft. It's an initiative with Guidewell Financial Solutions, which is like a credit counseling, and several agencies with the state. And we went to various locations in the state of Maryland to talk to people in preparation for the tax season. I find it very hard to believe, but there are members of my church who've gone through this where they thought that they were paying the IRS by purchasing gift cards. And I'm still trying to wrap my mind around that. But sometimes as we age and when we're sick, I know particularly for me when I was very sick, my mental capacity was not at the top. And so I think sometimes people are taking advantage of that, but there's still those people who are thinking that they can pay off the IRS through gift cards. So that's another thing to be aware of. And the person may have already been exploited, and there's something that you could do about it by reporting it. Most times we're not able to get the money back. But putting it on blast by reporting it to APS and appropriate sources is one way of dealing with it. And then there are people who may try and take advantage of you as a representative of that individual too. So you kind of have to be on the lookout for that. Some common signs of financial exploitation. You think some money or property is missing. The client says that some property or money is missing, and sometimes we don't listen to them because we're thinking they're older and they don't know. But listen, there's a message in what they're telling you, so be aware of that. You notice certain changes in the person's spending or savings. I had an elderly neighbor once that she finally, thank you God, decided that at 91 she didn't want to drive anymore. So we worked out something that she was using the same person to drive her. She still wanted to be out in the community. Most times on the weekends, I was the chauffeur for her. But during the weekdays when I was at work, there's this one particular taxi cab driver that was picking her up, taking her off. And I knew what the fare charge would be, but then I noticed she was giving him $50, $100, $200. So one day I happened to be off from work and noticed she didn't mention that she needed to go to the grocery store, which was like maybe 2 miles, if 2 miles away. And then I noticed the situation. He had entered into her apartment, and he kind of sized up that she lived alone and she had no one. So that's when I went up and offered to help put away the groceries, and I was able to question him, and I immediately notified the police. Now, it was embarrassing for her because she didn't want to admit that she was being exploited by it, but I could see that this was going to go further. He was trying to work up a relationship, and it was going to go a little bit further with that. So those things we have to be aware of as well. Sometimes it's a relative or a caregiver or a friend. I had a case in the District of Columbia back in 2013 and 14 where we had folks receiving the services of caregivers under healthcare agencies in their homes. And we got one case where, well, there was actually more than one because there were 30 agencies that were shut down, and a couple of people went to jail because their staff was exploiting the residents that they were supposed to have been taking care of, from stealing their pain medication. One lady had actually purchased a car in a gentleman's name, and he had Alzheimer's and he wasn't able to make that invention. I believe she got jail time as well. And then there was one that even tried to purchase a house or get an apartment in someone else's name. The most recent, if you might have heard, was in Montgomery County a couple of years ago, where there was this couple that offered to help this elderly gentleman with his affairs. She started out cleaning for him, but she became his power of attorney and started handling, and she isolated him from the neighbors and everyone else. And she and her husband financially exploited him. What makes this unique, and I think that you might have heard about it, is that once this was brought to light in Adult Protective Services and the Maryland, Montgomery County Attorney General's office, they were able to get a video of this man giving testimony of what had happened. And he died before they ever went to trial, but they were able to use that video in order to get a conviction. She had used his money for the casino, the Horseshoe Casino, Maryland Live. She'd actually paid for her daughter's tuition. They'd purchased 2 cars in his name. It was a series of things, but because they were able to question him while he was still living, they were able to use that video and admit it as evidence and get some closure with that. So these are some of the common signs, like I said, and you probably have more to add to this. And these are things to do if you think someone is being exploited. If they are in immediate harm or danger, of course, it's 911. But then staying in contact and having on hand the local adult protective services, the police or the sheriff. You may be required by law to do this. Some people are mandatory reporters. I know the ombudsman program in the district, we are not mandatory reporters. I don't believe you guys are here, right, Cheryl? We're not, okay. So, and then alert the person's bank or credit card companies. And it would be helpful if you had a list of these things beforehand that you can actually make that. Like I said, sometimes it's hard to get the money back, but once you alert them, I think for the credit cards, it's up to $50 if you do it in a timely manner. Then the bank, if they're FDIC insured, then you're able to recoup some of the money. Another option would be to call the local prosecutor or the state's attorney's office. And then there's always a long-term care ombudsman if the person is in a long-term care facility, or the state Medicaid fraud control unit, again, if they're in a long-term care facility. And you might think that if someone's in a long-term care facility, they're safe from exploitation. No, that is not the case. So you want to be aware of that. Then consider talking to a lawyer about protecting the person from more exploitation or getting money back if that's the possibility.